Coagulation is the process your body performs when a blood vessel is broken. It is a process designed to rapidly achieve temporary hemostasis and prevent major blood loss until a new endothelial lining can be formed. The ultimate goal of coagulation is to form what is depicted in this image. This is an electron microscope image of a fibrin meshwork. These fibrin strands span the vessel's rupture to create a temporary barrier preventing further blood loss. As we said, the purpose of coagulation is to prevent this, blood loss. It is also what allows us to perform and survive surgery. A non-functioning coagulation system can cause inappropriate blood loss. Thus, it is essential to surgical fields in general, but has increased importance in orthopedic surgery for the following reasons. An overactive coagulation system can lead to an intravascular thrombosis, such as this, a pulmonary embolism. We often see overactive or inappropriate coagulation clinically in the form of immediate postoperative complications following surgery. Previously, it was believed that fibrin, the product of coagulation, was critical not only to hemostasis, but also to stabilize bone fractures in assisting in fracture healing. Recently, however, the Shinneker lab at Vanderbilt University demonstrated that fibrin was not essential to fracture healing, and in fact, the removal of fibrin meshwork is essential to healing a fracture. Dr. Shinneker's lab also demonstrated that in osteosarcoma, the most common primary bone tumor in children, fibrinogen inhibits tumor angiogenesis and thus inhibits tumor growth. Finally, it is known that infectious bacteria such as staph and streptococcus specifically attack the human body by repurposing different elements of the coagulation system to aid in their dissemination. Thus, we can agree that understanding coagulation is of utmost importance to orthopedic surgeons specifically, but by influencing inpatient medicine, wound healing, pediatrics, cancer, and infection, it has relevance to nearly every medical field. We can divide the entire coagulation process into three parts: how a clot is made, how we dissolve this clot, and how coagulation fits into the body's systemic process known as the acute phase response to injury, or APR for short. Aligning these categories into clinically oriented topics, they each discuss an important clinical topic from hemorrhage and thrombosis to tissue regeneration, finally to infection and cancer. Today we will focus on the process of making a clot. This is the image that comes to mind when most people think about coagulation. However, we must remember that the coagulation cascade was designed by laboratory physicians for the purpose of monitoring warfarin treatment and was set up to reflect their experiments. It does not represent physiology and therefore is not applicable to dynamic coagulopathies in the OR or on the wards. Thus, it is not a clinical model. This provides us an opportunity to develop a new model of coagulation that is clinically oriented with the goals of assisting in clinical decision making. This then begs the question, what is a clinical model? Ideally, a clinical model is one that balances anatomy and physiology in a way that is easy to understand, easy to remember, and assists in clinical decision making. And that is what we did. The things we want to stress in our clinically relevant model are the importance of thrombin generation in coagulation, the cellular locations where coagulation occurs, and the concept of coagulation complexes. We believe that by better understanding these three things, thrombin generation, the cellular locations where coagulation occurs, and the concept of coagulation complexes, you will be better able to understand and correct coagulopathies you see in the OR and on the wards. This is an SR-71 engine. It is an exceedingly complex machine, but at its core, provides a very basic function. In the same way, coagulation is a complex physiologic process, but it serves a very basic function. Looking at a diagram of a jet engine, we see that its purpose is to take air in and produce thrust out. In the same way, coagulation takes the inactive clotting protein fibrinogen in and produces functional fibrin out. Thus, coagulation's primary purpose is to transform inactive fibrinogen into functional fibrin. Simple enough. However, this begs the question, what is going on in the combustion chamber of coagulation? To answer that, let's look at a representative vessel. This is a vessel at baseline. We all have coagulation factors constantly circulating through our vessels, but no coagulation occurring, which is good. We require some inciting event to initiate coagulation. This inciting event comes in the form of trauma, infection, or even surgery, which damages the endothelium to expose subendothelial cells to the bloodstream. When subendothelial cells are exposed to the bloodstream, this is the spark which initiates coagulation. So let's look at what is occurring with this spark. Here we are at the exposed subendothelium, which acts as our spark to coagulation. This spark can transform inactive prothrombin to an active thrombin. Then thrombin can cleave fibrinogen into fibrin, its active form. Remembering our coagulation engine, we see that thrombin is the most critical protease active in the combustion chamber. It is the flame which transforms our inputs into outputs in coagulation. But an engine does not fire once. It demands cyclical combustion to be productive. In the same way, coagulation is not meaningful if we only produce a single fibrin molecule. We need continuous and expanded fibrin production to seal our wounded vessel. Taking our engine example, what would we add to an engine to keep it running? We'd give it gas. In coagulation, the equivalent to gas is platelets. So let's see how platelets get involved in coagulation. Coming back to our vessel, we have exposed subendothelium which sparks prothrombin into thrombin. Then this active thrombin cleaves fibrinogen into fibrin. Thus we have the first and principal role of thrombin, which is to generate fibrin for our clot. But thrombin also has a second function involving platelets to create a positive feedback loop and self-propagating system. When thrombin is generated, if there is a platelet nearby, it can activate that platelet. Then on the surface of this activated platelet, more prothrombin is changed to thrombin, and that thrombin can then activate a platelet. And this process of activated platelets generating thrombin and thrombin activating platelets exponentially spreads and grows. Until we have a high density of activated platelets and thrombin molecules localized to the injury site. Zooming back out, we have our damaged endothelium with a critical density of activated platelets and thrombin molecules. Any inactive fibrinogen that flows by will be quickly activated and deposited over the injury site to form a fibrin clot. As we can see, fibrin deposition extends from the intravascular space into the extravascular space. To demonstrate this process in real time, here's a video of coagulation in a live vessel. Here you can see a vessel which is broken and radio-labeled fibrinogen molecules spilling out into the extravascular space. That's the dark green color. This dark green color transitions to a lighter green color, which is a fibrin polymer meshwork being formed. In addition, you can see activated platelets, as demonstrated by the red color forming inside the vessel. Coming back to our engine model, let's look at the self-propagation of thrombin generation and platelet activation. An initial injury sparks thrombin generation, which changes fibrinogen into fibrin, but we know thrombin has a secondary function to activate platelets. So, some thrombin generation leads to platelet activation, which leads back to thrombin generation and activating more platelets. This cycle of platelets to thrombin back to platelets continues until we have a fully active coagulation system which generates lots of fibrin to close our damaged vessel. From this model, we could describe a functional equation of coagulation, which is injured tissue multiplied by platelet amplification to produce continuous thrombin formation. Or, a spark times platelets equals a controlled thrombin explosion. At this point, you should wonder, isn't this just one more system to memorize? How does this equation help me to make clinical decisions? Well, if we look at coagulopathies, we find that both hyper and hypocoagulable states are products of over or under production of thrombin. Thus, every time you encounter a coagulopathy, you should first ask, what is going on with thrombin generation? This equation then breaks down the causes of altered thrombin production into pathologies of spark generation and platelet amplification. So how does that help us? Well, consider a situation where platelet amplification is decreased. What would happen to thrombin formation? It would lower our multiplier, thrombin generation would lag, and we would find a hypocoagulable state. Similarly, if we were to consider a patient with a systemic inflammatory condition, making them more likely to spark after a relatively minor vessel injury, we can see that we would generate a larger spark, which, when multiplied by platelet amplification, leads to increased thrombin production and a hypercoagulable state. These hypothetical examples of patients being prone to sparking or under amplification of platelets occur every day on the wards. What's more, they can be explained more concretely if we examine what goes on with spark generation and platelet amplification at the cellular level. Thus, we need to look at the anatomy and physiology of what is occurring at the cellular level. Here we will get to introduce the concept of coagulation complexes and how they are essential to understanding physiology and pathology of coagulation. This would be like taking our jet engine and focusing in on a critical smaller component, such as the fuel injector or exhaust valve. Coming back to our vessel, we will dive down on the area of exposed subendothelium. We know that this is where the spark is generated and an initial amount of prothrombin is changed to thrombin. Let's look at the spark generation at the cellular level. At the injured cell surface, we get to talk about coagulation complexes. And there are 4 elements to coagulation complexes that you should know. The first is, it is located on a cell surface. It has an anchoring cofactor. It has an activator protease. And it is named for the function it performs. In this case, we have built the extrinsic tenase, which serves the purpose of activating factor 10. Zooming out slightly on this cell, we see that when a cell is injured, it expresses tissue factor, which is our coagulation complex anchor. Tissue factor then grabs factor 7, its activator protease, and this forms the extrinsic tenase. This is our first example of a coagulation complex. Its role, as its name implies, is to generate activated factor 10. This activated factor 10 can activate a small amount of prothrombin to thrombin. Thus, we can see that the spark we have been referring to is truly the activity and influence of the extrinsic tenase, which is expressed on the surface of injured tissue to generate an initial amount of 10A to then form thrombin. Thrombin then can cleave fibrinogen into fibrin. But we know thrombin has a second role to activate a platelet. In the presence of a platelet, thrombin can activate it, which leads to 2 new coagulation complexes to be expressed on its surface. These 2 new complexes on the surface of an activated platelet are what accomplish the platelet's role in amplifying thrombin production, which we talked about earlier. Let's look at their contribution. The first complex is the intrinsic tenase, which, similar to the extrinsic tenase, has a role to generate activated factor 10. The second complex is incomplete and relies upon the tenases to be completed. Both the intrinsic and extrinsic tenase generate factor 10A. We can see that activated 10A can be supplied to the prothrombinase complex from either intrinsic or extrinsic tenase. So what is the difference between the two if they supply the same factor to the prothrombinase complex? The important difference between the intrinsic and extrinsic tenase is the efficiency with which they generate 10A. The difference in factor 10A production between the intrinsic and extrinsic tenase is the fundamental difference between the spark and amplification steps of coagulation. The intrinsic tenase is more efficient and designed to keep coagulation running, while the extrinsic tenase is more sensitive and designed to start coagulation. By completing the prothrombinase complex, the second complex on a platelet, it can fulfill its role to generate large amounts of active thrombin. This increased thrombin production can then cleave a sufficient amount of fibrinogen to form a fibrin clot and stop bleeding. To summarize, we can see that coagulation is the combination of an injured cell and platelet amplification to generate sufficient fibrin clot. Coming back to our equation of coagulation, we can see that when we talk about injured tissue and platelet amplification, what we are truly talking about at the cellular level is the activity of these critical coagulation complexes. The logical next question would be, what would happen if we lose one or more of these complexes? To answer that question, let's look at hemophilia, which is a classic example of coagulopathy. We saw in normal coagulation, the intrinsic and extrinsic tenase generate 10A to complete the prothrombinase complex. But they do so, importantly, at different efficiencies. We know hemophilia to be a genetic deficiency of either factors 8 or 9. In losing either of these factors, we lose the effectiveness of the intrinsic tenase. We can continue coagulation through the extrinsic tenase, feeding the prothrombinase complex, but it will be at a drastically lower rate and efficiency. Prothrombin can still be cleaved to thrombin, and thrombin can still generate fibrin, but it will be at less amount and less effectiveness than with normal coagulation. Coming back to our equation, we see that hemophilia is a problem with the intrinsic tenase, which can be summarized as a platelet amplification problem. We spent most of this time trying to build a clot, but slowing down or stopping coagulation is just as important as being able to lay it down. We don't want our engine getting out of hand like a runaway train. We need to have physiologic mechanisms in place to stop coagulation. So how do we turn off an engine? Using our equation as a guide, we can see that there are 3 areas of coagulation at which we can shut this process down, and our body has specifically designed systems to do just that. These are the systems we will walk through because they are all of clinical relevance, and they also are mechanisms clinicians leverage on a daily basis with pharmaceutical agents. Let's address the most basic one first. If thrombin generation is what all coagulation centers on, let's just take thrombin out of the system before it can cleave fibrinogen to fibrin. That would be really simple. In our engine model, this would be the equivalent of extinguishing the flame. Or, once an initial injury occurs and thrombin is generated, we douse that engine with water. This is exactly what antithrombin does. Here we are at the cellular surface, ready to undergo coagulation. We know that the intrinsic and extrinsic tenases generate an initial amount of 10A to complete the prothrombinase complex, and that generates an initial amount of thrombin. This thrombin is supposed to cleave fibrinogen. However, if antithrombin is present, it will covalently bond to thrombin molecule and prevent its ability to cleave fibrinogen. Thus, one of antithrombin's jobs is to act as a suicide inhibitor of thrombin. It would be difficult to discuss antithrombin without mentioning heparin as well, so let's see how heparin works. Here we are at the cell surface ready to undergo coagulation. We know that an initial amount of 10A is formed to complete the prothrombinase complex and generate thrombin, but this time, in addition to having antithrombin present, we also have heparin. Heparin will catalyze antithrombin's binding to thrombin roughly 4,000 times to prevent its cleavage of fibrinogen into fibrin. We can say that heparin's role in anticoagulation is to catalyze the activity of antithrombin. So that is how antithrombin and heparin work to stop thrombin activity and prevent coagulation. Let's look at another way to shut down our engine. Let's turn to the physiologic mechanisms for shutting down the platelet amplification step. Attacking this step would be like denying an engine its gas and letting it run itself down. Looking at our engine model, if our engine is running at full steam, if we break the positive feedback loop of platelets feeding thrombin, feeding back on platelets, the engine will eventually run itself into the ground as it loses all its gas, and coagulation will be shut down. The first way the body does this is utilizing antithrombin at a different location. Let's see how that works. Here we are at the start of coagulation, ready to generate an initial amount of factor 10A to complete the prothrombinase complex. However, even before thrombin is generated, antithrombin has an opportunity to shut down coagulation. It binds to that active factor 10 and inhibits the prothrombinase complex from ever making active thrombin. Thus, antithrombin provides a second mechanism for shutting down coagulation by preventing the prothrombinase complex's activity. So that is how antithrombin also works to decrease platelet amplification. Let's move to low molecular weight heparin as an example of us clinically leveraging antithrombin's activity on factor Xa. To start coagulation, Xa is formed by the intrinsic and extrinsic tenases to complete the prothrombinase complex. Antithrombin's job is to prevent this from generating more thrombin. Let's first discuss where low molecular weight heparin comes from. Low molecular weight heparin is exactly what its name implies. It is simply a stripped down heparin molecule. But what's great about it is that by making it smaller, low molecular weight heparin is specifically targeted to catalyze antithrombin's activity on the activated factor X. It assists in joining antithrombin to Xa and locks it in place to catalyze its inhibition of the prothrombinase complex. Shutting down the prothrombinase complex shuts down the platelet amplification step of coagulation. As we said earlier, low molecular weight heparin targeting is all about size. Low molecular weight heparin products are developed by creating a batch of heparin molecules and then separating them by size. Their size determines the specificity with which they attack Xa relative to thrombin. So smaller low molecular weight heparins have greater Xa activity versus thrombin activity. To summarize, we can say that low molecular weight heparin catalyzes antithrombin's activity on Xa to shut down the platelet amplification step of coagulation. Now let's talk about activated protein C and its effects on platelet amplification. In discussing activated protein C, we get to examine the contribution of healthy tissue to coagulation, and therefore must introduce a healthy cell to our model. So let's review how coagulation runs in the first place. An injured cell expresses the extrinsic tenase on its surface, which generates an initial amount of Xa to generate thrombin. That thrombin can then activate a platelet, which puts two new coagulation complexes on its surface. Both the intrinsic and extrinsic tenase can feed the prothrombinase complex on the platelet to generate an initial amount of thrombin. At this point, we are ready to generate fibrin. But if this thrombin molecule finds the surface of a healthy cell before it finds fibrinogen, what it signifies is that the clot formation has been sufficient and it's time to shut down coagulation. On the surface of this healthy cell, thrombin would find a protein C complex. It will bind and activate protein C. Protein C will then negatively feed back on the platelet amplification process at both the intrinsic tenase and prothrombinase complex levels, and its activity will be catalyzed by protein S to shut down platelet amplification. We can see that activated protein C is a very powerful physiologic mechanism to check coagulation in proportion to the amount of thrombin produced. In other words, it prevents coagulation from running out of hand and acts like a throttle on the engine model. To review, we have seen the way antithrombin, low molecular weight heparin, and activated protein C are all able to shut down coagulation at the platelet amplification step. Having introduced the negative feedback mechanism of activated protein C, we can now discuss the clinical example of when the activated protein C system is non-functional. This is the example of factor V Leiden. We talked about how activated protein C's activity is initiated by thrombin formation. Thrombin will bind to the protein C complex, activate protein C, which will negatively feed back on the platelet amplification step and be catalyzed by protein S to shut down platelet amplification. But what would happen if one of these platelet complexes that APC negatively feeds back on changes its shape? This is what happens in factor V Leiden. Thus, activated protein C can only inhibit the intrinsic tenase, which provides some benefit, but we can still feed the prothrombinase complex with Xa from the extrinsic tenase, albeit at a slower rate. Which allows for some thrombin generation and some fibrin formation. Thus, the clinical phenotype seen with factor V Leiden patients is that small injuries become large clots stemming from the inability to completely shut down the platelet amplification step. Now let's turn to the final way our body can shut down coagulation, which would address injured tissue spark generation. In our engine model, this would be like preventing a spark in our combustion chamber entirely, such that the engine can never turn on. Visually, it would look something like this. Without a spark, we generate no thrust. This is the way to think about tissue factor pathway inhibitor. We've talked about how, when a cell is injured, it expresses tissue factor on its surface, which grabs factor 7 to complete the extrinsic tenase to form an initial amount of 10A and generate an initial amount of thrombin. Well, the body can't prevent an injury from occurring entirely, but it can dampen its response to that injury. Let's watch this process again in the presence of tissue factor pathway inhibitor, which is a molecule produced by healthy endothelium to prevent coagulation. Tissue factor expressed on the surface of an injured cell grabs factor 7 in circulation to create the extrinsic tenase. But in the presence of tissue factor pathway inhibitor can block the formation of active factor 10 to cap the extrinsic tenase and shut off the spark. In summary, tissue factor pathway inhibitor stops coagulation before it even starts and addresses the spark generation step of coagulation. What is interesting is that physicians take advantage of tissue factor pathway inhibitor all across the hospital every day. You see these sequential compression devices on patients' legs used to prevent deep vein thrombosis after surgery. What sequential compression devices do is squeeze the healthy endothelium to stimulate tissue factor pathway inhibitor release, and then tissue factor pathway inhibitor circulates systemically. In fact, these SCDs, as they're commonly called, can be placed on any extremity to reduce the risk of DVT because TFPI, tissue factor pathway inhibitor, is a systemically circulating molecule. To review, this is the third way the body prevents coagulation, which is by dampening the response to injured tissue. And tissue factor pathway inhibitor is the physiologic mechanism. At this point, we have gone through our equation. We've talked it through forwards, how coagulation complexes at each level work together to generate thrombin and then cleave fibrin to form a clot. We talked about hemophilia as an example of deficient platelet amplification, which diminishes thrombin production and leads to reduced clot formation. We have also illustrated mechanisms at each cellular level which inhibit or stop coagulation. And we located these mechanisms, antithrombin, activated protein C, tissue factor pathway inhibitor, to specific aspects of this equation. We also noted the ways in which we pharmacologically assist these mechanisms. Those are the examples of heparin, low molecular weight heparin, and sequential compression devices. We've even gone past that to show how deficiency in these inhibitory mechanisms, such as factor V Leiden, leads to a clinically relevant coagulopathy you see on the wards in the postoperative period. But there are examples of altered coagulation which do not fall neatly into these categories. These are complex cases which involve alterations in multiple elements of this equation. The best example of this is Coumadin. What Coumadin does is inhibits the activity of vitamin K dependent coagulation factors. What factors are those? They are thrombin, also known as factor 2, factor 7, factor 9, factor 10, protein C, and protein S. Let's locate these factors on our diagram of coagulation. Thrombin, factor 7, factor 9, factor 10, protein C, and protein S. It appears that Coumadin shuts down both procoagulant factors, 2, 7, 9, and 10, and anticoagulant factors, protein C and S. So what is the net effect? Well, we find that protein C and S get shut down first, which is why Coumadin therapy is initially procoagulant, becoming anticoagulant over time. This explains why clinically we bridge Coumadin therapy with heparin to account for this procoagulant period. To review, these are the factors that Coumadin affects. But these are the factors we lose first, protein C and protein S, which leads to an initially hypercoagulable state. As we begin to wrap up our discussion, let's think about what categories coagulopathic orthopedic patients fall under in this equation. When we think about where this system is most heavily affected in orthopedic patients, we see that they mostly are conditions of exuberant spark generation. Both trauma and surgery are large injuries which induce major tissue damage and thus spark generation for coagulation. Infection and cancer are also causes of increased spark generation, but it is of a chronic nature. Infections and cancer are conditions of chronic hypoxia leading to chronic tissue injury and chronic spark generation. Then when we think of the post-surgical orthopedic patient, we see that deficiencies of the protein C pathway are commonly associated with thrombotic complications because of the inability to shut down platelet amplification. This is another major consideration in orthopedic medicine. In conclusion, I'd like to stress once again the utility of this equation for coagulation. It is simple enough for you to remember and provides clinical value when thinking about dynamic changes in coagulation and the therapies we employ to stabilize coagulopathic patients. Having understood how coagulation works, you are now ready for a discussion of clot dissolution and the fibrinolytic system. This will be discussed in our next video. This presentation has been a product of the Schoenecker Research Lab at Vanderbilt University.